So this actually is tuberculosis, Lyme's disease, triage tagging, acute kidney injury, chronic renal failure, and sepsis. Kind of a little mini review for my students, but I actually wanted to go ahead and record this. And so I hope this helps my students, and I hope it helps anyone else that's interested. So let's get started. So one of the things that we've been studying is tuberculosis or TB. As you look at this slide, you see the lungs over there. It is definitely an issue, a disease process that can affect our lungs. We know that. We talked about the history. We talked about people having to mask in their own homes to protect, others that are in their house. If we're in the hospital, we know that they're in a negative pressure room. We know we're going to wear an N95, and we're going to protect ourselves because it is actually airborne precautions. So we want to make sure that we put those masks on so we don't inhale the TB. If you recall, I talked about how fine and little it is, and that it just kind of floats in the air, and then we take big deep breaths in and we have tuberculosis. So we don't want that. The other thing with TB is that the signs and symptoms. So if you're having you could have active TB before you actually present with signs and symptoms, but normally we have a cough for around 3 weeks that will bring people in. We have night sweats, that's a classic symptom. Anorexia, we'll see weight loss. They could have hemoptysis with this cough down the way. If they cough, they can bring up a little blood. I referred to in class, if anybody has watched Doc Holliday on Tombstone, perfect. Val Kilmer plays that role beautifully, and that is a classic end-stage tuberculosis patient. This is back in the day before we knew what to do. You can have fever, chills, and difficulty breathing, dyspnea. They can have some difficulties breathing. So look and review your signs and symptoms of active TB. Understand those. Also go back and review how to administer a PPD. So you want to know how to give that intradermal sub-Q injection. Remember, it's 5 to 15 degrees. We go bevel up under the skin. We're going to inject that protein derivative that is for tuberculosis, and it's going to make a bleb. It's going to make a little teeny bleb under the skin there, a little bubble. And then what we want to do is make sure that we tell the patients that they need to have it read. If you are a healthy person, 15 millimeters of induration is a positive for anybody, including healthy people. If you are not healthy, it gets a little less. So some are less than 10, some are less than 5. But what I really want you to understand is you're going to give these, see these, read these. So if it is in duration of greater than 15, it is positive for healthy people, for sick people, for everybody involved. So just go back and kind of review that whole administration of that. I did go over it in class. There should be a PowerPoint on that. If not, you can refer to your book. The other thing is just your PPE for TB, our personal protective equipment. Go back. When do we wear an N95? When does the patient wear an N95? When does the patient wear a surgical mask? What does the patient need to do to protect others from getting TB? So go back and review that. There are 3 meds that we give. There's sometimes a 4th, but the 3 meds I do want you to go through and review. Remember rifampin? That's the one that turns all the fluids orange. Remember I said don't wear your good panties. It's going to stain the contacts. They don't need soft contacts. They're going to have hard contacts. You need to go ahead and review that one. Go ahead and review the other 2. They're broken down. They were discussed in detail in class, but those are the 3 drugs that are given for anyone that has tuberculosis. So I want you to go ahead and go back into the sepsis notes. I want you to learn where creatinine comes from, where the BUN is for your clinical piece, so that you can answer different questions, so that when you do your relevance maps, that you can connect those diagnoses to the lab values and what's going on. But I want you to review signs and symptoms of sepsis. There's a whole list in there. I also want to make sure that you understand that oliguria, which is less than 400 milliliters of urine in a 24-hour period, or less than 20 milliliters, less than 30, 20, anything under 20 in an hour is considered oliguria. That is considered a medical emergency. I don't care what you're doing. We have to make urine. We have to filter. And when we don't, if all of a sudden we don't, that's a major medical issue, and we need to be addressing calling the doctor and getting orders and figuring out what's going on with testing and seeing where we stand. Because what's going to happen is we're going to then have this shift in fluid, we're going to have a shift in electrolytes. It kind of all coincides. With sepsis, just review those signs and symptoms, and I think you'll do fine on it. So when you're looking at Lyme's disease, I want you to go ahead and look at how do we treat it. We treat it with antibiotics. So it's antibiotics over a longer period of time, usually 10 to 21 days. We'll give an antibiotic. I want you to go back and kind of look at that. Also, I want you to go back and review how to remove the tick properly. We always use tweezers, grab it by the head. I have a whole little sheet on it from the CDC of how to remove a tick properly, and try to get away from the old wives' tales. The other thing that I want to state to you about Lyme's disease is that no matter what, if the tick is in its head, it's down in there, it's attached to the body, you must remove the tick first. Get rid of the tick before we do anything else, because if not, it's just sitting there throwing up and spreading the bacteria that we don't want, the Lymes that we don't want. It's just going to make you sicker. So the tick comes first. Just remember that. Always, when you think of disease, anything going on, you want to remove the source that's causing the problem. So you remove it and then you treat. So just take a look back at that. Remember, it's from the deer. It's a deer tick. It's one of those little teeny black-legged ticks. They're so little, it's almost a speck, but they're the ones that reap all this havoc for us with Lyme's disease. So the AKI, chronic renal failure, acute kidney injury, and dialysis, I just put on one slide. But go back and look at your signs and symptoms of chronic renal failure. Those are the things that you need to know. One of the things with renal failure or acute renal injury is we have hypertension. So what I want you to do is understand, why do we have hypertension? Well, what we have is that filter won't get the water and get rid of it, so we're holding onto fluid, so we get volume overloaded. And then with a volume overload, it's going to create hypertension, right? We're going to have those issues. How do we control our hypertension in renal failure? We love a specific medication. I want you to go back. I talked about it today in the lecture, and it's really important. They are renal-friendly hypertensive medications, and I'll give you a quick little clue and a hint. One of them is that what is the classic side effect of the medication? That hacky little cough. And when you stop taking it, it goes away. So go ahead and take and review through that and look back on the lecture today. Go ahead and review your pre-renal, intrarenal, and post-renal. Pre-renal is anything above the kidneys. So that's where if you have a cardiac event, if you have an acute MI or anything like that, it's causing perfusion issues to the kidney, and that's causing the problems. If it's intrarenal, it's in the kidney. It's something dealing with the kidney itself, right in there. And if it's post-renal, it's going to be something that's obstructive or blocking there's different things out there that can cause issue. So go back and review that. If you have any questions, please reach out to me. On page 831 for my students in their Stromberg Elsevier book, read about peritoneal dialysis. Go through, it compares it to hemo, the pros, the cons. Look at that. Also, I want you to review epoetin. That is a drug. It is a hormone that we can give. And what does it do? We produce it normally and naturally through our kidneys. And what it does is it actually stimulates the bone marrow to make red blood cells. So if we're not making red blood cells, we're going to become anemic. That means we don't have oxygen carrying capacity on our red cells, and so we're just kind of sick. So we need this. We need red blood cells. So this is what we do, and we could give epoetin. So look that up. You need to know that one. And it's also known as EPO or EPO is what I say. Also, how to prep the patient for hemodialysis. Well, you don't really do anything with the fistula. You're not going to mess with that. You don't need to do anything, clean it. You don't need to do anything that. But one of the things you need to do as a nurse is realize what medicines to give and what medicines not to give. So always know that with hemodialysis, our biggest worry is hypotension. They're going to go over there, bottom out, come down because they're pulling the volume off, and then what happens is their blood pressure bottoms. So we don't want to ever give blood pressure medicines. Also, we want to hold because they're filtering the medicines out. So if we're filtering through the kidneys and they're medicines that are given and filtered through the kidneys, we're going to filter them out into the dialysate. So we don't want to do that. So we need to make sure we're clear on what we hold and what we don't. The two majors are we never give our antihypertensive and we never give our anticoagulant. So we will they'll hold them, and then you go by your physician's order afterwards. Go ahead and look under hemodialysis. So the last but not least is I'm bringing in triaging from back, tagging and triage. One of the things about doing it, it helps you start to assess and prioritize care. You triage everywhere you go as a nurse, whatever you're doing. You're always looking, assessing, and prioritizing care. Who needs to be seen first? Who needs to go here? Who needs to do that? When it comes to tagging out in the field, this is the start. And because I'm teaching this kind of in the emergent unit, looking at this, I want you to understand that if they're red, it's immediate. They need to go immediately. They need care. This is life or death. They need to go fast. Delayed is yellow. It's almost like the traffic light. You're holding them back. But the thing with yellow that I want to say is make sure you're always assessing and reassessing that patient, because they could turn from yellow to red. Something could happen and all of a sudden they need to go, and you would then re-tag them to red and get them gone for care. Green, of course, I always say green is go. They're okay. They might have some small abrasions or something that need to be dressed, but it isn't life and death. But black is expectant that death, that they're not going to make it from whatever injury. Now, they could still be alive at the time you're triaging, but looking at what's going on, you know it's not going to be an outcome that can be prevented. It's imminent death. One thing I want to say about this is that if you have the opportunity to be with that person, to give that person pain medicine to help them relax and be comfortable, please do so, because that's called being humane and having empathy. You want to be there, but, and I'm going to say a but, of course, if if you have 50 people and you're triaging quickly and you have people that you need to figure out, are they red, yellow, or green, and they're not black, then you need to go ahead and move on, and so that you can hopefully save a life. It's very sad, it's very hard, but it is part of what we do in the emergency world. So that is just kind of a brief overview. I'm hoping this will focus you so that it will help you. For my students, it will help them on their exam. They can kind of focus their thoughts. We've covered a lot of material in the past few weeks, so I just hope this helps. Talk to you soon. Bye.